Thank you. Okay, so welcome everybody. I'm gonna get our slides moving here and start with our disclosures. And as you can see, our disclosures are listed here. And I do want to add that, as Blake mentioned, Russ and I are both AVA board members, and this presentation does not reflect the position of AVA unless it's specifically cited. And we're also not going to discuss any off-label use of products, but Russ, I know that we're going to discuss that term off-label during the presentation.
Yes, we are, Lori.
I have to admit, Russ, I'm really both humbled and a bit intimidated to be joining you for this webinar today.
Well, Lori, I'm honored to be joining you. You're always so knowledgeable about topics, and you're always so well organized that hopefully you're going to keep me better organized on this topic.
Absolutely, I'll do my best. You know, Russ, I was thinking back and, as we've been going through the rehearsals on this and developing this presentation, it reminded me that really it was 2014, I think, when I first heard you speak at a AVA scientific meeting. And I remember you were a keynote that day, and you were speaking about strategies for reducing risk and liability for extravasation on that topic. But I think it was probably my second or third scientific meeting, and I still considered myself a newbie at the event. And I have to admit that you scared the you-know-what out of me. Your presentation was really thought-provoking, and at the end, it really reinforced my need to understand the risks and liabilities that can come from failure to meet standard of care. Like many of the hundreds of clinicians that were in that room that day, we all had what we thought was an understanding of standard of care, regulation, all the things that you're going to be talking about. I know I thought that my hospital's policy and procedures protected me, or my own professional liability insurance protected me. So it was very eye-opening, but that's the intimidating part. But I'm truly humbled, like I said, years later, to be joining you essentially on the stage here, which is really virtual, but collaborating on the same topic. So it's very exciting to be here.
Well, I always hate to be the scary guy, Lori, but I think, it's very important for clinicians to understand that there is liability in everything that they do. And the more knowledge they can have about where the potential risks and exposures are, I think the better they are able to practice, and the better they are able to provide better care for their patients.
Absolutely. I have our objectives up on the screen. I know they were shared in all the social media and the registration, but we are going to talk, like we've been mentioning, it's a mix of some of the legal perspectives, standard of care, but also how tissue adhesive and other securement meet that standard of care. So I won't go through that much longer. We have a list of abbreviations here. Many of them are familiar with most of the clinicians on this event today. I do use the term tissue adhesive, or TA, instead of the term cyanoacrylate, just because that's a little more challenging to pronounce. So Russ, as we get started here, one of my questions that I have is, we talk about the standards of care, and I'm a bit confused, and I'm sure many in our audience may be, regarding that term standard of practice. Why is INS publication a standard of practice and not a guideline or a recommendation or even something else? And is there legal implications to the different terms and terminologies?
That's really a great question, Lori. And it's a question that actually came up on a group that I was involved with. I think Judy Thompson was actually involved in that group years ago. And there are many questions and many issues with regards to the terminology that we use. And I hear this not only from clinicians, but even from attorneys and others who are using terms like recommendation, guideline, regulation, standard, and they use them interchangeably without really recognizing that they are all different and they all have different significance. So we're going to cover just 4 of these very briefly when we start off the presentation today. And when we talk about a recommendation, this is something that's generally initiated by the organization involved that has a certain amount of subject matter expertise. It's a statement of practice that I say potentially provides a health benefit to the population served. And the reason I say potentially is because a recommendation usually is applicable to a new topic, a topic that has little evidentiary support or acceptance at the time. So it changes. And that's why I use the potential term, because it may at one time be helpful and may at another time not be so helpful or even gain more help as we go forward. And it's also not binding on the practitioner. So this is kind of the lowest level in the terminology hierarchy. And I use an example, I'm going to use some COVID examples for the clinicians to understand the differences between the terminologies. So a good one to use for recommendations is mask wearing and social distancing. When the pandemic first started, there were a lot of recommendations that came out with respect to mask wearing. Should we wear a mask? How far apart should we stand from each other? We really didn't know. There was a lack of evidence. We didn't really have the data to support this. And as time went on, we now have a better understanding of the importance of masks and how far we should stand from one another, as well as the importance of social distancing. So we're going to talk a lot about evolution in this presentation, and I think that's a good example of how a recommendation kind of evolves over time. If we look at the next kind of term, we look at the term guideline. And again, a guideline originates within the organization very much like a recommendation. And it's a statement of advice or instruction pertaining to practice. So this is specifically for clinicians. But the difference between a recommendation and a guideline is the fact that a guideline has greater evidentiary support than a recommendation does. So it's a little bit higher on the terminology hierarchy, if you will. It's usually developed in response to a stated request or a need for instruction by a clinical group. So examples of this is CDC has guidelines, SHE has guidelines, ONS has guidelines. If we look at what happened during COVID, a good example to use for this would be the CDC recommendation that if you were potentially exposed to someone with COVID, you needed to quarantine for 14 days. Now, again, this was predicated upon some good evidence that we had at the time. But as we all know, this also evolved. This also changed to the extent that now I believe the recommendation for quarantining is shorter than the initial 14-day period. When we look at regulations, which are the next kind of strata in the terminology hierarchy, this is where the legal implications kind of kick in. With respect to regulation, with respect to recommendations and guidelines, again, no real legal requirements or penalties there. But with a regulation, this is something that usually originates within a governmental type body that has official authority and the power of law. So what a regulation does is it actually looks back at the recommendations and guidelines that we had previously and now puts that legal requirement around them, makes them a requirement for a legal operation. So to give you an example of this, when we talk about OSHA and we talk about COVID, OSHA is very big on regulations. And if we look at a recent OSHA regulation, which was 29 CFR 1910, for example, this was the regulation that required employees to regulate and protect required employers rather to regulate and protect their employees from potential exposure to COVID. And if you had a potential exposure, it required you to do certain things, including putting a respiratory protection plan in place, including making sure that you had the appropriate personal protective equipment or PPE available for your employees. So again, we're going up the ladder now: recommendation, guideline, now regulation, and finally we come to the top of the hierarchy, which is the standard. The standard is the strongest criteria we have set for a certain task or practice by a healthcare organization. So we're all looking now at the INS standards. And usually standards are validated by some pretty strong scientific or epidemiological evidence to back them up. It directs the clinician and tells them to do and not to do certain things and establishes accountability, meaning that the failure to comply with a standard can incur disapproval or even sanctions from the organization or from even outside the organization. But what gets really interesting about standards is that they are not required for legality. So unlike regulations, there's no legal component to standards. So non-compliance may not result in liability and vice versa. So complying with a standard doesn't necessarily mean that you're protected from liability. And this is very important for clinicians to understand. So don't think that just because you're complying with the standards, that you're going to be immune from potential liability. And we'll go into why that is in a few minutes. But examples of this clearly are the recent INS 2021 infusion therapy standards of practice. And this is a great standard. I mean, I can't tell you how hard Lisa Gorski and her team work to produce this standard, which is really an amazing and quality piece of evidence and literature that really needs to be understood and recognized and read by all clinicians.
Indeed. Yeah, kudos to that. I know clinicians all the time are talking about how their print copy is dog-eared already, within the first 6 months of reviewing it and reading it. One of the things I did want to ask Russ is on, I think it's page S12 of the standards this year, they delineate the strength of evidence and the body of evidence. Is there any legal significance to the levels of evidence? I mean, I see level 1, 2, 3, 4, 5, and then they have AP, anatomy and physiology, and committee consensus. Do I need to rely on only level 1 evidence, or are they all appropriate and good to use?
So, Lori, that's a great question. There is definitely some legal significance to the different levels of evidence. But what we need to remember is that in law, we talk about the standard of care. Here, we're talking about the standard of practice. They're very, very different. So when we talk about the standard of care, and this is what we lawyers are interested in, that's the caution that a reasonable person in similar circumstances would exercise in providing care. You've heard me talk about this many times. You can be wrong, you can make mistakes, but you can't be negligent. So negligence consists of having a duty to the patient and then breaching that duty, and then having some causation that results in potential harm and damage to the patient. And so to avoid negligence and to avoid malpractice, it's very important from a legal standpoint that you comply with the standard of care. We're not really looking so much at the standards, although the standards certainly will enter into this, but lawyers look at the standard of care. And the standard of care, unlike the standards, consists of potentially all practice guidelines, recommendations, and evidence-based medicine. Now, conceptually and in the ideal world, the standard of care should overlap with the standards, but many times, unfortunately, that's not the case. And so we're going to be examining why, in fact, the standard of care can actually be different from the standard of practice in some cases. So now let's take a look at that evidentiary pyramid that INS developed and really kind of explore what I mentioned in a little bit greater depth. So INS has a great evidentiary pyramid they've got a 5-tier pyramid, the top level being 3 randomized control trials or a meta-analysis. Then you go down to level 2, which is 2 randomized control trials, level 3 with 1 randomized control trial, level 4, which is 1 well-designed laboratory study. And lastly, we come to level 5, which is essentially the lowest level of evidence on this pyramid. Those of you who are familiar with levels of evidence have seen other pyramids, I'm sure, from organizations like Johns Hopkins. They have different levels. They have different variations within the pyramid. Here, INS has a 5-stage pyramid, but they also have 2 interesting levels at the bottom. A level called AP, which stands for Anatomy and Physiology and Pathophysiology, and Committee Consensus. And we have to remember that while these levels of evidence are important, they may not always coincide with evidence-based practice. If we look at the lowest levels on the pyramid, these lowest levels, which are anatomy and physiology and committee consensus, can still be used as evidence and are still valid if in fact you need to go into court. And let's take a look at what these mean, because to be honest with you, I didn't know what the category anatomy and physiology meant. And as a matter of fact, in the 2016 guidelines or standards rather, anatomy and physiology wasn't placed at the bottom of the pyramid. It was actually placed at the top of the pyramid along with level 1 evidence. And what anatomy and physiology is these are things which clinicians know to be true. These are things that essentially there is no evidentiary evidence for due to ethical reasons. So there's no known supporting evidence for these things. These are things that we know to be true and can't be tested. Lynn Hathaway was kind enough to give me an example of this, and the example she used was pulmonary emboli. You can't have one group or one control group having no pulmonary emboli and another group, the group having pulmonary emboli, and expect to get some evidentiary data out of that. It just is not ethically proper, obviously, to do that. So these are things that you just know to be true. With respect to committee consensus, this is also a very important category. And it's important because it also can be used from a legal perspective. But what's important to know about committee consensus is this is where you've got low quality or insufficient or even conflicting evidence. And so we really don't know yet where to place this on the pyramid. But the interesting thing about committee consensus is that this changes or may change every time the guidelines are put out. So we've got a 5 to 6 year span of time between the time the guidelines are initially put out and the time the next revision comes out. Well, what happens is items, and this includes things like tissue adhesive, they may appear as committee consensus to begin with because we don't have a lot of evidence about them yet. We don't have a lot of data. We don't have a lot of support for these things yet. But as time evolves, we get more data, we get more evidence, so that things that initially appeared as committee consensus may then, in the future standards, show up as level 1 evidence, as level 2 evidence. And this, the reverse of this can also happen. So things that may have level 1 or level 2 evidentiary support may actually be downgraded because of new things that we find out about these products or practices due to our experience and due to data that's published. And I can tell you that every time that either as a lawyer or as a clinician, you see the term consider, that should give you a key that this is probably a committee consensus statement that's going to be made, because while we want clinicians to take this into consideration, we don't yet have any evidence or data to clearly define where we want to put this particular item on the evidentiary pyramid. And now let's take a look at what Perry Mason would do with all of this legal data that I've just spouted out to you. So if you look at this picture here, you can picture Perry Mason being me on the left, and maybe Lynn Hadaway being the expert witness on the right. And we'll go over exactly kind of summing up what I just talked about. So clearly now you know there are differences between recommendations, guidelines, regulations, and standards. They have different legal connotations and they have different evidentiary connotations. We also know that within the standards, there are different levels of evidence. And the different levels of evidence do have different levels of support behind them. However, just because you have a higher level of evidence, this doesn't necessarily coincide with the standard of care, which is what we look at in law. Because in law, we not only look at the evidentiary evidence from the pyramids that we just talked about, but we also include evidence-based medicine. So we look at critical thinking. We look at keeping current. We look at incorporating the patient into our practice. And so while the standards will usually align with the legal standard of care, this may not always be the case, as the standard of care must be evidence-based. And as practices and products evolve, they may actually leave the standards behind, because remember, the standards are only changed every 5 or 6 years. And even that is a heck of a lot of work for all of these great people who work on the standards. And this is another good reason why clinicians out there should always have their own professional liability insurance, because don't think that just because you're complying with the standards that you're going to be 100% protected from potential liability.
That's a really great summary there, Russ. But are there potential or other issues related to adhering to the standards of practice?
Yes, so the standards, as I mentioned, one of the problems with the standards is the best that any organization can do is to try and come out with standards every few years. And INS does a remarkable job doing this every 5 to 6 years. But even in that 5 to 6 year period of time, things can be outdated. In addition, no matter how good the clinicians are who are working on these standards, some bias is going to enter into their decisions and into their recommendations based upon their own experience. This is only natural. In addition to that, as I mentioned before, evolution has to happen in these standards. So what happens is the standards can actually constrain innovation until enough people are making changes that actually a new standard of care evolves. And actually, finally, the standards, as I mentioned before, they actually can conflict with evidence-based medicine, because an important tenet of evidence-based medicine is keeping current. And so now let's take a look a little bit more deeply at the main components of evidence-based medicine. So if we look at critical thinking, I like to think of this very simply. For those of you who are not so familiar with evidence-based medicine, is don't just keep doing something because everyone else is doing it. What I learned in healthcare, the most dangerous words are, this is how we've always done it. And this is why those words are so dangerous. Shelley likes to use the words, that's what Shelley likes to use the terminology, I believe she calls it, what's in it for me? And it's the same kind of thinking, because we shouldn't keep doing something just because it's in the standards if we're not getting the results that we should be getting. And a legal case that I use to kind of highlight this is the case of Barbara Helling in a case called Helen V Carey. Those of you may have heard me talk about this case before, but it's a very important case to highlight the issue of critical thinking. Barbara Helling was a 34-year-old woman who got new contact lenses. She went to her ophthalmologist because she was having problems with the lenses. Her eyes were itching. They were tearing. He didn't think anything of it. She was 34 years old. He gave her drops. He told her to come back if she still had a problem. Sure enough, a few weeks later, she's still having problems. Her eyes are actually getting worse. He gives her more drops. Finally, after several weeks of this going on and Miss Helling getting continuously worse, she decides to go to another physician and get another opinion. And she's ultimately diagnosed with wide-angle glaucoma. She sues her original ophthalmologist, who says, we don't give glaucoma tests to anyone under the age of 40. So when she sues him, the court actually says that despite the fact that this is not typical in the industry, that despite the fact that you don't usually give this test to anyone under the age of 40, reasonable prudence based upon Miss Helling's symptomology, in other words, critical thinking, would have required you to give her this test, and therefore found the ophthalmologist liable. The same applies to keeping current. As I mentioned before, and we're going to go into this when I return, very, very important to keep current, because things that may be committee consensus now may ultimately evolve into being level 1 or level 4 or level 3 or level 2 later on. And Lori, this kind of ties in with tissue adhesive, because tissue adhesive was originally something that I saw in the 2016 standards as being committee consensus. And now I see that tissue adhesive has actually been elevated to level 1 and level 2. And there's been a lot of talk lately about the failure of PIVs. And so is tissue adhesive helping us to reduce or prevent that opportunity of peripheral IV failure?
It sure is, Russ. Tissue adhesive, as you said, it's a great example to use in this discussion, because like you said, it didn't get a lot of mention in 2016. And certainly the rapid progress that we see is attributed to vascular access specialists and researchers that are attending this webinar today that have tracked outcomes, they published data and shown its effectiveness. So having only been on the market for 3 years, and it's really expanding in its use, and the growing body of evidence really propelled it to become one of the 4 recommended securement technologies, along with other recommendations, which I think sometimes aren't as highlighted, but aiding hemostasis and providing a barrier to microorganism growth, reducing catheter failure, and also improving dwell times. So when we talk, what went too fast here? So when we talk about peripheral, IV failure, catheter failure, as far as that goes, we definitely need to take a whole new approach on this. We keep hitting a brick wall on this one. And it's really time, like you said, to really apply critical thinking and innovation. If you recall, in 2015, Dr. Helm and his associates, Dr. Helm is a cardiothoracic and vascular surgeon, and he and his colleagues published a really thought-provoking article called Accepted but Unacceptable. And they set out to examine and understand why peripheral IVs fail so frequently. And they reviewed the literature and found that even with dedicated vascular access teams in place, our peripheral IVs were failing at greater than 63%, and even higher in some cases, up to 90%. Of course, we know that peripheral IV failure has been a daunting problem for a long time. It's not something new to us since 2015. And then in 2018, a large, randomized controlled trial was published, and over 1,800 peripheral IV insertions were reviewed, and it's called Securing All Intravenous Devices Effectively, or SAVE, they call it. And that study really gave us an in-depth look at comparing dressings and securement methods for peripheral IVs. So I'd like to take a little deeper look into that study. And like I said, it contained a review of over 1,800 peripheral IV placements, and they randomized patients to receive either a standard polyurethane dressing, a bordered polyurethane dressing, a securement device with polyurethane, and tissue adhesive with a standard polyurethane dressing. And their goal was really to look at what the optimum securement or dressing method for peripheral IVs would be. And they define optimum as the most conducive to a favorable outcome. So it's when we talk about the evidentiary pyramid, this is a randomized controlled trial. So it really contains important information that we should be reviewing. So the conclusions of this, if you look at the article in depth, it really highlighted that none of the interventions, what they called significantly reduced peripheral IV failures. But when you really drill down the numbers, even if the percentages appear small, the numbers are huge when it comes to peripheral IVs. They looked at securement bundles might offer some effectiveness. They did say that the occlusion rate was significantly lower with tissue adhesive and the standard polyurethane dressing. And also that, obviously, I think we are comfortable saying that the cost with just a standard polyurethane dressing alone was less, but improved dressings and securement was definitely needed. And the optimal method, they said, was still elusive.
So Laura, you know I have a little problem with this study, and my problem is that I come up with a different conclusion from this study, as I typically do when I look at clinical articles. But what I clearly can say is that while a solution to prevent 100% of catheter failure, certainly we still don't have the answer to that. But clearly, this study did show that tissue adhesive, along with standard polyurethane dressings, did perform better than the others. And in addition to that, the other thing that I find is interesting is, with respect to statistics, is that while the numbers or the statistical significance may be so little, when we look at the numbers and the number of PIVs placed annually around the world, these numbers can be huge.
Exactly, Russ. Oh, here we go again. So here, I appreciate that comment, because I took an opportunity here to break this down and look at the differences in terms of numbers from the SAVE study, and looked at the failure rate, the occlusion and dislodgement. And you're right. When you talk about 1 billion peripheral IVs inserted worldwide every year, and just even the typical hospital placing 100,000 peripheral IVs every year, these numbers can be huge with just a simple application of tissue adhesive to improve the outcome. So if you look at failure, for example, 8 to 9%, is that significant? Yes. When you look at 80 to 90 million peripheral IVs not failing per year. The same with occlusion, between 3 and between 6 and 7%, up to 7%. Again, 30 to 60 million catheters not occluding. And dislodgement rate, 0.5 to 1%. Again, that number seems small, but when you put it in perspective of 5 to 10 million peripheral IVs not failing, it is huge. So when we look at what's gone on since that SAVE study, so after that 2018 SAVE research was published, then in the ECRI, or the Emergency Care Research Institute, they included peripheral IV harm in its annual top 10 patient safety concerns. And for those of you not familiar, ECRI is an independent nonprofit organization, and they look at safety, quality, cost effectiveness across healthcare settings worldwide, not just across the United States. And then also in 2019, Dr. Helm, he provided a follow-up to his article of accepted but unacceptable. And the good news in 2019 is that he reported that the failures were less accepted, but what he found was that the cause of short peripheral IV failure still exists. And essentially, the simple transparent dressings that we're using don't provide adequate support and protection. And we're doing the same thing essentially, but expecting a different result. And many hospitals and clinicians changed our policies and procedures during that time to a clinically indicated protocol for our peripheral IV, but we really didn't do a lot different. I think we did a great job educating clinicians on assessment and scores for phlebitis and things like that, but we didn't change the things that maybe really needed to be impacted. Dr. Helm stressed the need that we needed to look at, his recommendation was that we provide stabilization, which is clinically simple, highly reproducible, and cost effective. So I think those 3 terms are very significant when we talk about some of the new technologies. So then we fast forward to 2021 and the latest INS standards are published. They include tissue adhesive, like you said, among 4 other recommended securement technologies for vascular access. And they come with additional recommendations, like I mentioned before, to manage bleeding and oozing, and also providing a microbial barrier. And unfortunately, peripheral IV peripheral IV harm is still ranking in the top 10 patient safety concerns with regard to ECRI. And this is their publication, a snapshot of their publication that just came out this year, looking at these top 10 patient safety issues. And number 9 includes reducing the rate of peripheral IV infections, and they specifically call out proper catheter securement in its top 10 concerns list. And they recommend research and using proven technology, which we're talking about today, that reduce infection. There's that term, they say consider sterile techniques. So I'm sure we will hear more about that as more evidence evolves. And also components of proper catheter securement. Tissue adhesive, as far as I understand, is certainly a proven technology, and this addresses each of these recommendations that they are mentioning here. And of course, we know tissue adhesive is one of the 4 securement technologies that's listed in the INS standards that came out in 2021. We know that vascular access failure is not just limited to our peripheral IVs, and it's likely the reason that really INS called out more specifically technologies for securement in the 2021 standards. And more important, I think that as we continue to hear reports of outcomes and publishing data, we continue to get the evidence that's needed to recommend these technologies. Every patient is unique, Russ, and they need unique securement, and we should take that into consideration. And also, just like we do with device selection, we need to base that based on the patient's specific needs. I like to point out too that tissue adhesive can be used with as a primary securement. So for peripheral IVs to any vascular access device, it can be combined with any of the other technologies that are mentioned here on this slide. There are no age restrictions and device limitations for using tissue adhesive. So it's also compatible with other products like CHG gels and patches or discs. And so if clinicians choose to, they can use them in combination or, like I said, as a standalone securement and for its other benefits. So Russ, tissue adhesive offers a really, in my opinion, a very unique opportunity to secure, stabilize, and protect all vascular access, including our peripheral IVs, which are really a huge problem. Though it's relatively new to us in vascular access, cyanoacrylates really have been around for decades. And like we mentioned now, it's really rapidly evolved into the vascular access space. But I always like to point out that cyanoacrylate or tissue adhesive have been in use and now further developed and tailored specifically to what vascular access needs are. So knowing this, I'm wondering, is there a legal justification to use new technologies such as tissue adhesive? And is this true even if it's not specifically in the standards? And I guess a follow-up question to that is it okay not to use it?
So the evolution of products ties in directly with evidence-based medicine and keeping current. And tissue adhesive is a very good example of this. So as many of you have heard me say before, malpractice standards change not because of changes in the law, but because of changes in technology. So as technology changes, malpractice standards change and liability changes. And that's why technology that is readily reliable, reasonably available, won't harm the patient, and that you're competent to use must be used. And this is true even if there is not universal acceptance of this. So even if only just a few practitioners in the field are using this, but they're having good results, even if the technology isn't high up on that evidentiary pyramid, even if You don't have randomized control trials yet because we know they're expensive and they take a lot of time. And companies, a lot of times with some of the greatest products out there, don't have the time or money to do them. You need to keep current. A very important case that I mentioned where liability was found against the defendants had to do with the failure to use continuous oximetry monitoring. This was a case back in 1992 where a plaintiff was left in a vegetative state because they put the endotracheal tube into her esophagus. And as a result, she had a lack of oxygen, and had they had continuous oximetry monitoring during the procedure, the clinicians would have realized that the woman was suffocating, and they didn't realize this. And so even though at the time, very few facilities were using continuous oximetry monitoring, there were very few papers actually published on it, the defendants were held liable for medical malpractice for the failure to adopt this new technology, even when very few people in the field were using it. And it's only okay not to use new technology or not to consider incorporating new technology if it does involve new clinical risks for patients, or if it changes the underlying process of care, or if there's a problem with the FDA approval, or if there are some questionable clinical trials. In addition, it's okay not to use it if you might need some special training or competency which you don't have, or if the process or practice requires resources that you don't have, or if the product needs maintenance that isn't available, or if in fact you need to get informed consent from the patient, which you can't get. And lastly, but maybe not least importantly, the cost. If the cost is prohibitive and it outweighs the benefit, again, that's another reason where it would give you an excuse not to incorporate new technology that's had proven success in the field.
So Russ, I'm curious, we mentioned the off-label usage, which of course won't be in the guidelines. How do I know if it's okay to use something off-label?
So off-label usage actually, Lori, ties in very well with this whole concept of evolution and how to expand product use. And there are a lot of questions always on the forum, especially on the vascular forum, about, is this off-label use? Well, the reason we came up with off-label use to begin with is because the FDA was very aware of this requirement with evidence-based practice to keep current, but they also realized that it was impossible for a government organization to keep current. It's barely possible for INS revising their standards every 4 or 5 years to keep current. So what they did was they came up with this principle, this doctrine called the Learned Intermediary Doctrine, which essentially delegated this responsibility to the clinician expert so that you as the clinician were thought to be in the best position to make this decision for your patient, in the best interest of the patient, to consider new products, to test new practices. And that's why it's so important that you listen to webinars, that you go to seminars so that you know what's out there and you know what people are doing. It's not illegal to use something off-label. And as a matter of fact, just like other things have evolved, off-label usage may eventually evolve into the standard of care. And as we know, in kind of fields of practice like psychology, oncology, pediatrics, off-label usage is almost the standard because we don't have a lot of good products and a lot of good evidence out there. But if you're hearing about other good success in the field, this may give you reason to consider off-label usage. And off-label usage, again, doesn't have to agree with the standards, and it's rarely going to be in the standards. I will tell you that if you can prescribe or use on-label, you're always going to be safer. But there are times when you should consider off-label usage. And those times are if it's in the best interest of the patient. So if you're doing this in the best interest of the patient without fraudulent intent, if there's some urgent or emergent reason or urgency that you really need to get a solution out there, you need to reduce the opportunity for an adverse event to occur. If in fact the potential benefit outweighs the risks that you're knowledgeable about, That's another good criteria for you to use something off-label. If you know that it's been used successfully by other practitioners in the field, and as I mentioned before, this doesn't require uniform use. It just requires that you know of some other knowledgeable and successful practitioners who've had good results. That can give you enough criteria and ammunition to use something and feel comfortable using it off-label. And you don't need to get informed consent from the patient for this. It's best to get it always, as we know, but it may not always be possible.
Thanks, Russ. So focusing on tissue adhesive for a moment, how would you be able to defend its use in court? And if so, what arguments would you make for use?
So tissue adhesive is one of those beautiful products. There are many of them out there, but what I like about tissue adhesive is two things. And now that you know the difference between standards and standards of care, you'll appreciate this. Tissue adhesive is supported by the standards, and it's also supported by the evidence. So if we look to the standards, right, if we look to the INS standards, what do we find? We find tissue adhesive mentioned in sections, I think, 38, 42, 50 as level 1 and level 2 evidence. We also find that this level 1 and level 2 evidence is based upon the fact that tissue adhesive has been found to be bactericidal, it's hemostatic, it reduces catheter dwell time, it's superior to sutures, and it can prevent catheter failure or reduce catheter failure. So we've got ample documentation from the standards. And we also now have, as you mentioned, Lori, some randomized control trials that are supporting this. If we look to the evidence, we look to evidence-based practice, right? So we look to that critical thinking, we look to keeping current, we look to protecting and incorporating the patient into our decision-making process. So if we look at critical thinking, it's been used very successfully by many people in the field. There's a lot of good data coming out about the use of tissue adhesive and the benefits around preventing catheter failure and improving outcomes. When we look at keeping current, this is a technology that's evolving. It's technology that's readily available, reasonably reliable, won't harm the patient, and anyone can use it. I even use it. So it's very, very easy to use this product. And lastly, incorporating the patient. And what does it do for the patient? Prevents infections, prevents dislodgement, reduces occlusion, reduces infiltration, and also protects against skin injury. I think there are good studies about MARCI with respect to this product as well. So I feel very comfortable using this product. In addition, it does have the FDA approval, and the added benefit is it's pretty cheap. It's low cost. So there's a good return on investment for using this product as well.
Is there an argument to be made of not using technology? And would that be a breach of the standard of care?
Yeah, so, with preventability comes liability. So years ago, when nothing was thought to be preventable, there was very little liability. Now what happens is every year, more and more and more and more is deemed to be preventable. Again, this is because of product and practice evolution. But with this preventability comes increased liability. And so as an attorney, when we look at malpractice, what we do is we ask the question, is there some technology, product, or practice that could have prevented the adverse event with minimal risk, cost, liability, and competency? And if so, why didn't you use the product? And this is the question that we'll ask if there's catheter failure and tissue adhesive or another type of securement was not used. And can catheter failure, which is attributed to the failure of securement technology, be considered negligence, especially when there's good products out there that could have reduced the adverse events? And how can you justify permitting catheter failure, infections, dislodgement, occlusions, when there are securements out there, devices out there, such as tissue adhesive, that could have reduced these adverse events? So lastly, to summarize and to finish up, hopefully most of you have stayed on this webinar because this is the most important slide. So you could have ignored the rest of it. And as long as you listen to me on this slide, you'll pretty much get the gist of it, just like most of my presentations. All comes down to the last slide. So what are we going to do, right? What do we do? What's our call to action? Well, we need to compare the standards that we have out there, these great standards that just came out, with our hospital policy practice and identify any discrepancies. But remember, just because there's a difference doesn't mean there's a problem, because things are evolving. But what it does mean is that you've got to evaluate the reason for the problem. What's the rationale for the discrepancy? Is it a lack of competency? Is it because we don't have the resources or the products available? Is it because maybe the standards are outdated? Remember, 5 or 6 years is a long time. Things may change in 3 or 4 months. So why is this happening? And once we figure out why, then we need to institute changes to either comply with the standards, if that's possible and if it's warranted. Because if it's not warranted because the standards are outdated, then what we need to do is to document why we're not complying and include any backup supporting evidentiary data that you have, and demonstrate any alternatives to what you're doing to complying with the standards. And lastly, we want to document all the discrepancies identified between our hospital policy and practice and the standards and what we did. And you want to be sure that whatever you do, you document this in writing to risk management and or legal in writing, because I will tell you that should there be an adverse event and it was caused because of a failure to identify the discrepancy and evaluate it and make change because of the discrepancy, the finger may be pointed at you. So to sum up this presentation, since we're just about out of time, we've learned now the difference between recommendations, guidelines, regulations, and standards. We know that within the standards, there are different levels of evidence, but all of them can be used in court. But we also know that the standard of care and the standards, while we like them to be the same, they may not always 100% overlap. And that's because the standard of care, which is the legal standard, includes evidence-based medicine, which includes critical thinking, keeping current, and incorporating the patient. And keeping current may be very, very difficult to do because standards can only be updated every couple of years. So remember, standards and products and practice are evolutionary. And while the standards should be used as a guideline, be sure that they don't constrain you. Be sure that they don't constrain you from limiting the incorporation of new products and practices, which could actually reduce adverse events and improve the quality of care for your patients.
Thank you, Russ. That's an excellent summary of this presentation. I know that Blake and Judy will pop back on.
Just waiting for the invite, Laura. So
there you go. I was like,
happy to be here. That was a fabulous presentation. So thank you both.